back to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm Amanda Mixon, here with Jessica Glennie, and this is part 2 of our EULAR ILD RhAPP Up series. In our last episode, we covered some great data on ILD, and today we're going to dive into more. So let's go ahead and get started. All right, I'm going to talk about abstract AB1234, Early Disease Course of Systemic Sclerosis-Associated ILD, a real-life analysis from the SOLAR registry. So an overview of this study, this real-world registry analysis evaluated the early longitudinal course of systemic sclerosis-associated ILD using data from the nationwide SOLAR registry. Investigators focused on short-term lung function trajectories during the earliest phases of disease. The background and purpose for this study: ILD is a major contributor to morbidity and mortality in systemic sclerosis. Although many studies have focused on long-term progression, less is known about how lung disease behaves early after the scleroderma diagnosis. This study aims to characterize early lung function changes in patients with newly diagnosed scleroderma ILD and better understand patterns of progression versus stability in the first years of disease. The methods of the study: so data were obtained from the SOLAR registry, a multi-center registry of patients with early systemic sclerosis, defined as less than 3 years from non-Raynaud disease onset. Among patients with radiographically confirmed ILD, 130 individuals with baseline and follow-up pulmonary function testing were included. Forced vital capacity trajectories were analyzed longitudinally and across consecutive 6-month intervals. Patients were categorized as having clinically meaningful decline, stable disease, or improvement based on changes in FVC over time. The results of this study: at baseline, patients generally had preserved function despite early disease, and most were already receiving immunosuppressive therapy. Longitudinal analysis demonstrated substantial variability in lung function trajectories between patients, but no consistent pattern of rapid early decline. During the first 6 months, nearly 2/3 of patients remained stable, while only 14% experienced meaningful FVC decline. Similar stability patterns persisted throughout subsequent 6-month intervals up to 18 months, and overall stable lung function was the most common disease course observed in early SSc-ILD. The authors' conclusions were that in this real-world early SSc-ILD cohort, lung function was more commonly stable rather than rapidly progressive during the early disease course, particularly in patients receiving immunosuppressive therapy. However, investigators also noted substantial heterogeneity between patients, emphasizing the importance of individualized monitoring and ongoing longitudinal assessment in systemic sclerosis-associated interstitial lung disease. Okay, Jessica, what do you think of this?
Yeah, so, at first, it kind of gives you a little sigh of relief. Okay, well, these scleroderma patients with just early ILD, we're not going to see them rapidly declining. They're going to stay stable. But I do want to caution that these are patients that we have to follow very closely. And as it's stated, particularly in patients on immunosuppressive therapy. So if you have a patient that you haven't started immunosuppressive therapy, there might be more risk of progression in those patients. It'd also be interesting to see what pattern, this is talking from a pulmonary person, what pattern of injury is going on with these different patients and if there's a difference. So if a patient has something like NSIP versus UIP. So UIP is kind of the one that's generally a bit more progressive, and we see that generally in a more progressive type of pulmonary fibrosis called idiopathic pulmonary fibrosis, whereas NSIP we see most commonly in autoimmune diseases, but like scleroderma, but can see UIP as well. So, we would expect maybe a UIP pattern might progress more quickly. So you might have to keep an eye on those patients more. It also depends on whether it's fibrotic or not. You can have what's called a cellular NSIP versus a fibrotic NSIP. And so if a patient doesn't have much fibrosis, if it seems more inflammatory, there's more ground glass, they may respond better to immunosuppression and not, progress as much. So I think there are, some of these little things that we have to think about with each individual patient. I will also mention that even patients with IPF, which is a very progressive pulmonary fibrosis, when we catch them at a very early stage, and I don't have a study to say this is just, Jessica, Jessica right here speaking, but I do notice that generally people stay pretty stable for a few years. Then as something happens, whether it's genetic or whether there's some sort of environmental thing that kind of kicks things off, then sometimes it starts rolling along at a faster pace. So this is great news, but I just want to caution these patients need to be continued to be monitored as an individual and based on, kind of their pattern and what's going on with that patient. But we need to probably be keeping an eye on these patients quite frequently every 3 to 6 months in the pulmonary world.
One is the same from a rheumatology perspective too. It's also kind of interesting because a lot of times in diffuse scleroderma, like their skin actually progresses pretty rapidly and then slows down.
Mm,
And so it's just kind of interesting to see this from the lung perspective. But I totally agree. I mean, I think that this further reiterates, again, early detection, early treatment, and hopefully, the great majority of our diffuse scleroderma patients, we have on immunosuppression off the get-go to try to slow the disease progression as much as we absolutely can.
yeah. Yeah, absolutely. And then you can kind of catch any small changes and get them on appropriate therapy, whether that's, starting immunosuppression, different immunosuppression, or like an antifibrotic. So yeah, early detection and frequently seeing that patient longitudinally.
Awesome. All
Awesome.
right.
Okay, so we're going to go on to our second abstract. So our second abstract is the safety and tolerability of nerandomilast in patients with autoimmune disease-related progressive pulmonary fibrosis in the FIBRONEER-ILD trial. Overview of the study. This analysis evaluated the safety and tolerability of nerandomilast in patients with autoimmune disease-related interstitial lung disease and progressive pulmonary fibrosis from the phase 3 FIBRONEER-ILD trial. Background and purpose. Nerandomilast previously demonstrated a significant reduction in forced vital capacity decline in patients with progressive pulmonary fibrosis with a favorable overall safety profile. Because autoimmune ILD patients often receive background immunomodulatory therapy, this analysis examined whether nerandomilast remains safe and tolerable in this subgroup, including patients who were and were not taking immunomodulatory medications. Methods. Patients with progressive pulmonary fibrosis, excluding idiopathic pulmonary fibrosis, were randomized to nerandomilast 9 milligrams twice daily, nerandomilast 18 milligrams twice daily, or placebo. Safety outcomes were assessed across the overall study population and in the autoimmune ILD subgroup, with additional evaluation based on baseline immunomodulatory medication use. Results. Among 1,176 patients treated in FIBRONEER-ILD, 325 had autoimmune ILD. Most commonly in this was rheumatoid arthritis-associated ILD and systemic sclerosis-associated ILD. More than half of autoimmune ILD patients were receiving immunomodulatory medications at baseline. Treatment discontinuation due to adverse events was similar across nerandomilast and placebo groups. Diarrhea was the most common adverse event, but rarely led to discontinuation. Weight decrease occurred more often with nerandomilast than placebo, while upper respiratory tract infection and pneumonia rates were similar across groups, including among patients on immunomodulatory therapy. The author's conclusion, nerandomilast demonstrated a favorable safety and tolerability profile in patients with autoimmune disease-related progressive pulmonary fibrosis, regardless of baseline immunomodulatory medication use. These findings were consistent with the overall FIBRONEER-ILD trial population and support further consideration of nerandomilast in autoimmune ILD populations. Okay, so I have a lot of thoughts about this, but I don't know. I'll throw it to you, Amanda, if you have any thoughts based on this, if you've taken care of any of the nerandomilast patients yet or anything like that. What are your thoughts?
I have, and, of course, not nearly what
Yeah.
you're seeing, and I really work very closely with my ILD colleagues for
Yeah.
this, but it does feel like people are tolerating this better than, the former medication that they were on, and so at face value, when I read this, I wasn't surprised because that's kind of what I've seen clinically.
Yeah. Yeah.
I'm very
Absolutely.
interested to hear what
Yeah.
your thoughts are.
Yeah. Yeah. So, you know, I agree. I agree. Nerandomilast is being tolerated very well across the board with all of my patients, whether they're IPF or autoimmune ILD, whether they're on other immunosuppressive medications. It's very well tolerated. Sometimes diarrhea, stomach upset, things like that, but generally very well tolerated, much better than nintedanib, which is the other antifibrotic that we had approved for progressive pulmonary fibrosis. The one thing that or a couple things that I'll note is just because I know these Fibroneer ILD trials pretty well, while yes, about half of them or so were on some immunomodulatory medication, they excluded some of our favorites. So they excluded mycophenolate, rituximab, and then tocilizumab and cyclophosphamide. But mycophenolate and rituximab are two of our faves, at least in ILD. And so those were excluded. So these are patients on methotrexate, azathioprine, and I think Plaquenil were the most common. And although that doesn't, I mean, mycophenolate sometimes can cause some diarrhea and things like that. So, but I will say, even in my patients on mycophenolate nerandomilast, it's still been well tolerated. So I'll say that. The other thing I wanted to mention is some of these patients were on nintedanib. So there were patients who had been on a stable dose of nintedanib for 12 weeks could stay on nintedanib and have nerandomilast on top of that. So they did see that there was more diarrhea in the group that had nintedanib. Actually, everything I'm saying is still all very positive for nerandomilast and the side effect profile, but I just wanted to throw that out there that there's a little more nuance to it, but it's been well tolerated with our patients.
Well, and I think too, I think it's one of those things that, again, just having interstitial lung disease is so scary for people. And then, to be put on various therapies and, we really are putting them on a lot of stuff. And so to have a therapy that potentially could slow disease progression, but also be better tolerated, I think is just a win-win.
Yeah, yeah. So we used to have to tell people, look, I'm not going to make you feel better because none of these antifibrotics make patients feel better. It just slows progression. But I'm probably going to give you diarrhea and make you feel awful. I'm going to make you feel worse, not better. So now I can offer something that, I can say with more confidence, look, side effects are quite rare. You're not going to feel better, but hopefully you're not going to feel worse on this. So it's definitely a win. It's a win.
Absolutely. Well, that's a wrap for part 2 of our EULAR ILD wrap-up series. Thank you for listening, and don't miss part 3, where we will cover even more ILD data from the 2026 EULAR Congress.